Hi students, I am going to go over your E&M assignment and just explain a few things. Keep in mind there is explanations for wrong answer. If you got the correct answer, it's going to say great job, which yes, of course you did a great job. But for this first case, we have Maria. She comes through the ER. She was admitted to observation with nausea, vomiting, and dizziness. The doctor did comprehensive history, a comprehensive exam, and the medical decision making was of moderate level. Okay, so right here it's textbook. We have all three key components hit with a 99219. Okay, so we don't want to do ER first because again, she came into the ER, went and got admitted to observation. So she was, after 24 hours, they decided that they're going to continue her care. And at that point, it's going to be a subsequent observation care. So we don't do another history. So on that note, we have, let's go ahead and look at the documentation. Problem focused exam. We have a low complexity decision making. Let me pull that over. So that's going to be my 99224. It wasn't moderate. We can't upcode, can't be a moderate complexity. That was an option up here. Okay, so then the very last day we have a 99217, which is our observation care discharge. So 3 days, and we have 3 different observation codes. Okay, so let's go here with number 2, Max. We have a good SOAP note here with a subject. This patient was having trouble with their endotracheal tube leaking. He was afraid of losing airway. The objective, again, keep in mind, is the examination. The assessment, here's kind of major thing going on here. The patient is in respiratory failure. They did take a chest x-ray. The patient does have congestive heart failure. They are retaining fluid. The heart's normal. Patient has atelectasis and pneumonia. So let's look at the critical care time. This emergency room doctor spent from 3 o'clock to 4 a.m. and it was emergent. After they stabilized the patient was then transferred to ICU. So we need to code a 99291, which is critical care. And it didn't matter if you put ×1 or just left it by itself, but it shouldn't be a 99285 emergency room visit. We're coding just for the emergent care for this hour. Okay, number 3. This one's a little bit tricky. We have a 20-year-old male dropped off at the emergency department with a knife sticking out of their chest. The patient was not conscious. No one accompanied the patient. They were seen by the attending physician. Physical exam was less than comprehensive. It was noted that wherever there was a peripheral pulse, the knife handle quivered. The attending physician initiated trauma team mobilization, ordered diagnostics. Partial history was obtained, documented by the physician. 20 minutes after the patient was brought in, the on-call trauma surgeon arrived. At that time, the emergency department physician, Dr. Allen, transferred the care to the surgeon. Dr. Allen did document that the patient was unconscious and immediate threat to life. Dr. Allen was also unable to obtain a comprehensive history or an exam due to the patient's clinical presentation. Medical decision making, of course, was high and complex level per the documentation of Dr. Allen. Let's just go over a few things here. The code should be the highest level of ER, emergency, department. we didn't get a comprehensive history, they didn't get a comprehensive exam, but the medical decision making was very high. So, usually presenting problem are of high severity, they pose an immediate significant threat to life or physiological function, which that is what we had. But here's another little thing that you should have learned is that sometimes the patient's clinical condition poses an immediate threat to life, which this does, making it possible for the physician to use a higher level code, even if it may not be possible to perform the required history and physical examination. And that is exactly what we did in this scenario. So that is why we have a 99285. Okay, let's go to our next one, which is Lucy Fields. She is a patient who presents to internal med. And keep in mind here that Lucy just moved to the area of Southern California. So this means she is a new patient. So we have a rash. So let's get right to Dr. Rodriguez documents an expanded problem focused history. So let's just pull over our book. So expanded problem focused history is a 99202. Okay, I need all three key components. So I can tell you, just looking at this right now, it doesn't matter unless my other two are down here. So let's go ahead and look at this. So expanded problem focus history. We have a detailed exam, which is a 99203. And lastly, on this one, we have the medical decision making, which is moderate, which is all the way up to a 99204. Okay, one thing to keep in mind is that we can't upcode. Since we need all three key components, I have to go to the lowest component, which is history. So my code's going to be a 99202. Just because, again, we have to have all three key components. Okay, so Lucy came back. She returns, was seen a month earlier, okay. She's at the same medical practice. Same medical practice. So she's no longer a new patient, even though she's seen a different doctor. They're both in internal medicine. Now, this gets a little bit different if, let's say, she went to, it's a bigger practice and she was internal medicine and then went to orthopedics for a different issue. At that point, orthopedics could charge Lucy as a new patient. So let's go ahead and check out what we have going on here. Keep in mind, we only need 2 out of the 3 key components. So we have a problem-focused history, which is way down here to 99212. They probably didn't take that big of a history because they took a history last time. So with that, we also did a detailed examination. That's a 99214, even though our history is way down here. They also did medical decision making is moderate, which is right there, the 99214. So we have a detailed exam, moderate complexity decision making. I only need 2 out of these 3 key components, which gives me the 99214. So that is what our code is for that. Okay, so our last one here is, I shouldn't say our last one. With this one here, we have Oliver Smith. Okay, with Oliver, we have, it's going to be consult. And the reason is the attending physician calls in Dr. Fleming. Dr. Fleming wants to provide insight and treatment advice on Dr. Smith's dermatology issue. So again, they're calling in a physician who has a specialty to check out the patient. So with that, we're going to go into the consult area. And with the consult, let's look at our key components. We need all three. So with this, we have comprehensive history. We have a moderate level of medical decision making. So far it's a 99254, comprehensive history, moderate decision making, and then my exam, let's go ahead and check out the exam here. Let me pull this over. Comprehensive exam. So it puts us all rated a 99254. If anybody has questions on that one, let me know. Okay, so the last one here is an emergency room. With an emergency room, once again, we need 3 out of 3 key components. We need all three. So this patient here, we have detailed exam right here at a 99284. We have a moderate level of medical decision making, okay, which is a 99284. And my history is an expanded problem focused history. So unfortunately, my history wasn't detailed, so I have to downcode because all three of these here have to be met to code a 99284. So with this one, it has to be a 99283. So if anybody has any questions, hopefully you listened to the video completely. Just to let you know that I did post in there that E&M is changing 2021. Some of the codes are just going to be based on medical decision making and time. So that's going to be interesting, the new code books, and I have some information coming out about that. So when I do get that, I will pass that along to all of you. Please let me know if anybody has any questions. Contact me.